Hello, everyone, and welcome to today's OR Manager webinar titled Perioperative Nursing at the Breaking Point and How We Can Fix It. My name is Sharon Van Wicklin, and I'd like to welcome the attendees and also thank our sponsor, MobileSmith Health. Now, before we get started, I have a few housekeeping comments. Today's session is being recorded and it will be available on demand in the OR Manager store. We will take questions at the end of the discussion, and we encourage you to submit your questions in the Q&A tab section on your screen. Your questions will only be viewable by the presenters, not by the attendees. If you experience any kind of technical difficulties, please be sure to use the chat feature, and a webinar technician will come online to help you. You can earn one continuing education unit after attending this webinar and completing the quiz that will be available in your OR Manager account. I would now like to introduce our speakers for today's webinar. Alina Lazel, unfortunately, will not be joining us. She has COVID. Sammy Placer is the Senior System Director of Perioperative Services at the Upper Allegheny Health System. For more than 20 years, Sammy has held senior roles across perioperative and surgical services, clinical education, and nursing. Jennifer Missajet is the First Choice Vice President of Operations and Patient Care Services and Chief Nurse Executive for Trinity Health. Jennifer is an accomplished healthcare executive who leads nursing, acute, and ambulatory care delivery strategy, operations, and execution at the local, regional, and national levels. With deep perioperative experience, Jennifer is successful in building and leading high-functioning multidisciplinary teams, change management, and effective physician partnerships in interim and permanent roles in the perioperative setting. Miranda Woods Duncan is the Director of Perioperative Services at the University of Louisville Health Jewish Hospital. Miranda has been a registered nurse for 25 years. She has a clinical background in surgical services, critical care, and education, and she is dually certified as a nurse executive and nursing professional development specialist. She has 17 years of progressive experience in transformational leadership in progressive experience and nursing professional development. It is now my pleasure to begin today's presentation, and I'm going to pose the first question to Jennifer. Jennifer, the institution of nursing has a rich and proud history of caring for all humanity. To set the landscape of this conversation and the challenges that we face as nurses, how would you characterize the current state of the institution? And if we don't turn things around, what are we at risk of losing?
That's a great question, Sharon, and happy Tuesday to everybody. Happy to be here. The nursing profession, I think we're all aware, has weathered so many storms, but we are currently in the middle of extremely rough seas. Some would say it's unprecedented, but as you go back and look through the history of nursing, maybe not so. It's just unprecedented to us. And so I think we are at a place where we have to iterate and start to create our chapters of the nursing history to go forward. We're really at an inflection point. To keep along with the weathered many storms analogy, I think a lot of us really wanted to kind of go back to the old ways. And what we're finding post-COVID is that the old ways are not a safe harbor for us. Doing things the way we used to do them is really not working. There are a lot of new challenges that nursing is facing that we have to adapt to. For example, workplace violence and workplace safety. Those are new challenges for the profession. Also, yes, we have nursing shortages, but a lot of times it's due to our sick colleagues. Some of that is things we are not used to, and as well as the supply shortages, which I know for us in Periop, every day we report What are we low on? What are we on allocation on? So I really think that is the state of the profession today, and doing things the old way is not a safe harbor. So if we can't turn things around, what do we stand to lose? In my mind, I think you could say simply the nursing workforce, but I just feel like it's more nuanced than that. If we can't get to a more meaningful and effective place, I feel like nurses will lose their sense of purpose individually. And I think the profession, which sometimes is noted by Florence Nightingale and her lamp, will certainly lose its flame. So there's an imperative that we have to be able to weather this storm like the people whose shoulders we stand on weathered storms before us. Thank you, Sharon.
Oh, that was just a great response to that, Jennifer. And you had mentioned nursing being at the breaking point. So if someone had said nursing is at the breaking point 10 years ago, there might have been some mild objections. However, currently, with no objections or very few, people might now say nursing is broken. So are we at a point where we literally need to blow up the traditional nursing model and design a model that meets the needs of both patients and nurses? Sammy, tell us what you think about that.
Good afternoon. Well, the easy answer is just a simple yes, but it's definitely a lot more than that. Our entire healthcare system is very fractured, and it's become more apparent with this pandemic how broken we really are. At this point, we know what we have is not working, and we need to break the whole thing down and start over. This whole notion of just trying to build upon what we have isn't working any longer. We need to take a step back and be willing to accept that we're going to break this all apart. We're going to find out what works, what doesn't. We're going to take the time and have the longevity to say this isn't something that broke down in a day. It's not something that's going to get fixed in a day. It's going to be something that's going to take years for us to be impactful on. We're going to learn a lot of things in this journey of how we rebuild it and make things better. Our major workforce in healthcare is built up of nursing. Nursing is where we need to start a lot of these processes of rebuilding. We need to address a lot of the things that, Jennifer had kind of alluded to. Our workforce is changing. The things that nurses want today are very different what they wanted 5 years ago, 10 years ago. So we need to start adapting to what our workforce needs. Within that, a lot of people want more flexibility in their workplace. They want to be able to have some flexibility with their schedule, make sure their compensation is what they're looking for. They want to have work-life balance. A lot of these, even though it sounds super familiar to us, these are newer things that people are starting to adjust to in the healthcare world. So we need to make sure that we're delivering what our staff needs, but also maintaining that balance of what our patient needs and providing great medical care for our patients. So it's a great balance that I think that a lot of our new executives and great leaders are on a great path to start just rebuilding this. Like I said, I think this pandemic showed us that it's time for us to break things apart piece by piece and rebuild it back up.
That's great. And, it kind of made my heart flip a little bit when you said we need to meet what our staff needs. I think that's really important and such a thoughtful perspective. This question, I'm going to kind of address it to all of you. Balancing the use of traveling nurses with employed nurses. I know this has been a challenge for a long time, and the pandemic has just totally amplified it. What are some of the specific challenges with traveling nurses, and why has this now become a critical point?
I guess I can.
Boy, I'll take a stab at that, Sharon, just from my perspective, and then toss it to the group. I mean, I think the difference with travelers now is, today's traveler is last week's peer. So many people have decided traveling is what they want to do and the way they want to do it, that it's just kind of unprecedented. And so I really feel like, and I'm actually working for First Choice, which is part of Trinity Health, and that's an organization that provides alternative workforce to our hospitals. So I really think there has to be things like very good onboarding, a buddy system from the facilities, as well as clear defined processes, because there is a contingent workforce out there. My data shows that about 30% of nurses are interested in alternative work schedules and employment models. So if we can set them up for success through better processes, better buddying and onboarding, that traveler stigma may improve. But I would like to hear from everyone else what you guys are thinking and experiencing too.
So one thing we have seen, I think you always kind of struggle with the engagement piece when you have temporary and contract staff, because now last week, this week's traveler is last week's peer. I feel like that's affecting our regular staff more and more as well, because they know that they're coming in and the travelers are making more money. They're not necessarily happy about that. So they get a little disengaged too. And it's really hard for the organization to really um, make them feel appreciated and be as flexible as they can be when they take those contracts and can go travel. It definitely, we've had some come back, because I see somebody said in the comments that traveling is very hard lifestyle, and we are seeing that a little bit now, and people are getting tired. So we have had some return to their home jobs, but I think overall we're not seeing that much yet. We're kind of holding out hope that that will happen in the end when this all kind of settles down, if it settles down. But I'd say engagement is a huge piece. And then really feeling like you're kind of stuck in the mud as far as being able to do some process improvement things, because with staffing the way it is, and when you don't have people that are engaged, it's hard to push through on even small improvements, because people just aren't interested and engaged in making that change right now.
And I can speak for some of our challenges that we find in rural areas with our traveling nurses is that there's just not the amount of traveling nurses that want to come to these rural areas. We're not as exciting as some of the other places that they want to go. So we struggle a lot more with even obtaining nurses to get to come up to our areas, because we're just not as, we don't have the places to go and the fun things to, to do for a traveler. So we see a lot of trouble even obtaining those travelers, and a lot to Miranda's point, engagement is a huge portion for us as well. And travelers are at such a need right now. They're kind of holding the stick here, because, I've never seen it before until this year. We'll have travelers leave the second day they come, because they just felt like they could go someplace else where it fits them a little bit better, to where in the past we often saw travelers, they would at least, even if they weren't the best fit or they loved the environment, they would stick out their assignment and kind of persevere, to where now they're okay saying, listen, this isn't for me and I'm out. So we're definitely seeing a lot more challenges with our traveling staff coming to rural areas.
Wow, those are really interesting points. I know myself, I never really thought about, I've worked alongside travelers, but I've never really thought about the fact that they might be less engaged than I am, because they don't have any ownership, so to speak. I know most of the conversations that I've had regarding travelers has to do with the fact that they're being paid so much money, so it's up to them. They're kind of, sink or swim. You're making twice what I make. So yeah, that's been some really interesting insights there about travelers. You guys have any thoughts on how to fix that?
Well, I think the thing that I see, and, just kind of taking a look at the chat a little bit, this is a hot topic. So we probably do need to think about it. I think thinking about travelers differently, and some folks put in the chat, we got to come up with alternative work schedules. I mean, and when I shared that 30% data point, it really means that the people that are our own staff don't necessarily want to work 312s or 5/8s or 10, we have to be creative enough to find out what the traveler lifestyle offers without having to live out of a suitcase. So if it really is that flexibility in scheduling, or even that ability to float across facilities, we have to figure out what it is the workforce is attracted to, because it's true. We got a lot of our travelers back. The lifestyle is a bit grueling, even if you can travel with your pets and all this other kind of thing. But if we could figure out what it is that's attracting them to that, I think we as the employers need to offer those types of things, because COVID's changed everything for people. And if it really is, my kids are not in school routinely, so I need to be able to pick my shifts. So if my kids aren't in school, I'm home. Something as simple as that. I think we've kind of always had a mindset of this is the way you need to be to work here. And I think the travelers are beating us on that, because they're saying, what do you want?
Mm-hmm. Other thoughts?
Another thing I see that Heather brought up in the chat, that talking about people generally now stay 2 to 5 years in a position and move on. So perhaps that's something we could harness and look at doing something shorter, internships or externships for nurses where they can change specialties and do different things. So they don't have to go somewhere else to get that different that they're looking for. Because sometimes we put nurses into holes and then we don't let them out of there, and we don't give them the opportunity to keep learning and expanding if that's what they want to do. I think another thing is definitely those lifestyle options, and we've started looking at some of those kind of things. And I heard a consultant recently say that's what they called them, were lifestyle positions. So they had call positions that got paid their full-time FTE just to take the call, which really helped the rest of the staff that is not real huge fans of having that call every night after they've worked all day. We've got a couple of things like that that are on-call only positions that are a little bit different. They have a different rate of call pay just to kind of take some of that burden off. And I think we're going to have to look, because at some point I know we've been offering insane incentives to work extra, pick up extra shifts, do extra contracts. But at some point they will tell you, I just want to go home and have dinner with my family, right? So, and nothing takes the place of that. So we really have to start looking at how we can balance this. And a lot of the reading I've been doing and a lot of the articles that are coming out are dealing with mental health for healthcare workers. And I think that's great. But I think if you are not addressing the issues in the work-life balance, you're really missing the boat.
And I think that some of the topics that we can start, all of what we are talking about should start back in nursing school. I think, preparing some of our nurses when they start out of truly what work is going to be like, and how we can start to, when we're rebuilding all of this, new design, start right with those new nurses, have them help us develop some of the thoughts and ideas that they're looking for in the workplace too. This will help us develop a design that works for the people that we want coming into this workforce, and developing it with us. I think that would be helpful to try to we don't want to limit, but I think there are a lot of people are getting into traveling nurses because they don't feel like they have any other place to go. Maybe they just want to not be stuck in the day-to-day routine of a hospital, not meeting their needs. Maybe they don't want to do the type of nursing that's not available in their area. I think it gives us a lot more opportunities for advancements for those early on good thinkers.
Yeah, I know we're really talking about traveling nurses, but I have to say this as an older nurse, and I think a lot of those same things apply to older nurses. You hear that conversation over and over and over again, especially in perioperative nursing. Is there a point at where I can stop taking call? I'm 55. Is there a point where I can stop taking call? And we see that on discussion boards. That's really a hot topic, because a lot of the older nurses would like changes in schedule and some different things as they get older, and we want to keep those nurses in the working force a few years more, I would think.
And I do see in the chat someone wrote in very short sentence but true, um, doing it for the money or putting up with the administrative politics. That has always been true. And some of my people that were leaving said, I'm going to do the same work. And if I'm getting paid $200 an hour to do it, as opposed to whatever, then it's going to be a big difference because it is combat pay. And so if you can make it, you're going to do the same exact job if you're permanent or if you're a traveler. So I really think that to really, if the intensity of work is not addressed, and I think you kind of started with that, Sharon, we are going to have people who feel very transactional, um, and very sort of, I'll do it while I can till I can't stand it anymore. And then I think that bringing up the part about not being able to do process improvement and quality and stuff, you don't build that teamwork. And in Periop, that is so critically important. If every day I'm working with a new team as my scrub and my circulator, it just doesn't feel like you're as safe. You can't work on any of those things. People are just morphing in and out. And I think right now money is talking, but I think that at some point, and I think everybody, all of us have experienced this, there isn't enough money at some point to get people to saddle up and come in for one more day. And that's when the burnout kicks in. And $500 an hour is not going to get you people. Like even the traveler companies now say, we can't get people because people are just done. And I think that's what we're trying to think about in this webinar with all of you, is if we really are at the breaking point and you can't even pay enough people to do the job, then how do we change the job and how do we support the people in it? Because that's going to be the next step we have to take, because money's talking right now, but at some point nothing will be enough.
Mm-hmm. Oh, that was just great. Great discussion. This question is from Miranda. And Miranda, I'm going to ask you to turn up your volume a little bit. Some of the folks are having a little difficulty hearing you.
Okay.
With the dangerous combination of increasing patient volumes and decreasing nursing support, are we failing to meet the standard of care? More importantly, are we systematically compromising patient care?
So when I think about this question, obviously I think about our PACUs across the country right now, where we are holding and boarding patients waiting on beds. So yeah, I feel like we are really pushing the envelope with standard of care, and it's not well understood by our non-clinical leaders. And it's not for lack of us trying to kind of explain that, and it's just sometimes they just don't get it until something bad happens or almost happens, and then there's a light bulb that goes off. And what I hear from nurses and patients is, yes, at times we're not meeting the standard of care, and it's becoming more and more frequent, because nurses are specialized too. And at my hospital, we do a lot of things that you don't see anywhere else. So you could be a PACU nurse for 15 years and walk into our PACU and see something that you've never even heard of. So I think that we have to be sensitive to that, and nurses are not nurses. I think we all know that, but really helping other people to understand that. And I really don't feel like it's with ill intent, because we're caregivers and we all want to make sure everybody's taken care of, and we don't want to close the door or defer a patient to another facility. So we're all trying to do our part and take care of as many patients as we can. It's just that we don't have the nursing support right now either to pull that off. And I think that's, the nurses know it. And I think that's where you get into that moral distress issue. They know they're not giving the best care that they're capable of. I'm sorry, I don't know what's wrong with my mic. Still a little too soft, evidently. Um, but I think that's where we see a lot of burnout, is because they know it's not their optimal care. They feel like they're in survival mode. Um, and that moral distress really wears on them, and that's where you see the burnout really hit hard, and they think about leaving nursing.
Mhm. And fatigue too. They're tired, I think, and they're more likely then to make mistakes or to compromise their patient care. Yeah. I'm going to give you this next question also, Miranda. Do you think we're using technology effectively to bridge those gaps in care? Are there ways that we could be partnering with our patients and their families to provide care in a way that uses technology more effectively and maybe takes some of the load off of our nurses?
I think we definitely are not. I'm sure some places are, but I feel like when it comes down to being in a pandemic, you're not generally looking at bringing in new technology. But there are a lot of things I feel like that we're doing that's duplicating work, it's duplicating charting. Um, we're increasing the workload on nurses because our data is bad. So we end up manually collecting things that, we should be able to get out of a system. And we're doing a lot of things I feel like that with patients, those reminder calls and those things, and make sure you do your HIPAA bath before you come in. That could be more automated and take nursing out of that and take some of the workload off of them for those kind of things, and really make sure that we're looking at um, the things that nursing is doing are really top of license practice. They're really value add for nursing and to the organization and to the patient,
Mhm.
because we can't afford to have busy work and non-value add work anymore.
And I think our patients are a lot more tech savvy too. I know my dad is 90 and he loves when he gets a message on his cell phone. If he was getting instructions on how to take care of his wound or whatever, he would absolutely love that. And I think he would be more inclined to comply with the instruction because he has a positive energy about that. Yeah. All right, let's go to our next question then. And this one I'm going to kind of split between Jennifer and Sammy. So, what are the top two actions that you would take right now to address some of the challenges that we have discussed? So, Jennifer, make your solution one that would fall within the context of not necessarily unlimited, but very liberal financial responses. And then, Sammy, make your solution one that falls within the context and the constraints of your current health system.
Geez.
So I feel blessed that I got the unlimited resources. That's good. But I guess what I would say first is, and we know in many cases it really is bodies. But if the top two actions that I would take right now is, and I'm fortunate that I'm going to be able to do some of this in real time. We've got to take away from the pandemic what worked. There are a lot of things we can pull forward. And the first thing I would do is for people that looked at care delivery teams, all of those types of things, don't reserve them for a pandemic. When your ICU is full and you're proning patients, that's not all due to COVID. When you're in the OR and you're trying to manage ramping up again and doing a high volume of cases because you've got backlogs and you've put resources to that, don't save it for an emergency. So I would absolutely first sit down and say, what served us really well? I had an anesthesiologist tell me the other day, getting rid of blocks during the pandemic was the most efficient thing we ever did. We got so many more cases done. We didn't fight about things. So would block redesign be one of the first things to do for this, very perioperative focused audience, because we're caught in the dogma of that. So I would look at that first, and then I would look at the ancillary and support staff that can make these engines run. Because I think, periop, they always say, oh gosh, it's the engine that runs the hospital. Well, it takes a lot of fuel. And so I think we have to say, if there are two people that would like to split a 12-hour shift or pay those call teams. I would really look at resources and say, don't save them for a pandemic. Use them now because they do make you more efficient, and the return on the investment is preserving your workforce and getting more volume done. That's what I would do.
Great solution. Sammy, what are your thoughts now? You're on a limited budget.
I know. I feel like Jennifer could have went a lot bigger. Mine is going to sound very similar to hers. I do believe we kind of, again, a lot of the same things that we did discuss, going back to the flexibility with our schedules and the resources that we have. You know, I have this little budget you told me I had to work with, and in there, I know what staff I have to work with. So I need to go back to that staff, and I need to identify how can we make it work with what we have. That may be a little bit of what Jennifer started to talk about, sharing some shifts, being some flexible, you know, this works for me, this time works for me, let's work with this together. You know, having to make sure that we have the staff that's hired for what we're supposed to have. So we have sometimes open positions that we just don't know because we might not need them. So going back to that, we already have that structured in our budget. Let's make sure that we actually are hiring those nurses and having them available. Having the technology, I think that's huge right now to talk about, in the fact that sometimes technology can be such an advancement that we can utilize nurses doing a lot of other things and have technology kind of helping us out, kind of offloading some of those things. And some of that technology is not expensive. It's just something we have to adapt and get used to.
Mhm.
You know, sometimes our staff has a little bit of stumbling blocks, but once you get there and you start using that technology, sometimes it makes your days go much better, much smoother, and take a little bit of stress off the staff. And I think that's what we're looking for. So those are the two things I do.
Yeah, I agree with you. And I guess I can't even imagine an unlimited budget. So I probably like scope myself in, but I agree with you because the technology, the teams, the adjuncts. I mean, one thing I feel like we should say is that all of the people working should be working at the top of their license, because we do see a lot of nurses doing work that really doesn't need to be done by the nurse. And that makes the intensity of work so much worse when they're hunting and gathering and, you know, really doing things that someone that doesn't have their skill and expertise could easily do. Invest in those people. There's a lot of talk right now about nursing scribes. This was hot with the physician team, and it's really helped with burnout for physicians. And if my EHR is not great and it takes me forever to go look in there and find an implant, you know, give me the technology where the stuff is in there, but then give me some support. So I'm using my top of license skills to take care of that patient, not doing work that somebody on the ancillary care team could support me with. I think that would really help and also show the value to the profession, because we are plug and play, and that knowledge cannot just be substituted. So let's make sure that's what the nurses are spending their time on.
And I can tell you, with my unlimited budget that I just stole from Jennifer, my staff would love me to like build a great big house close to the hospital with all the amenities so that they could stay there when they're on call, feel close to the hospital. Maybe we'll even give them some services that they can get right back to the hospital quickly, unlimited meals. I could go all day on that.
They can bring their family, right?
That's right.
Yeah.
Pets.
Yes.
Yes.
That's all good for everybody's hearts.
Oh, you all have been delightful. And I'm going to say thank you for sharing your participating and your sharing your insight. And so we're going to open up now for question and answer. And there have been just a ton of comments coming in about the pay and increasing the pay. And so I don't want to move on without maybe addressing that a little bit as to far as, you know, the discrepancy in pay between travelers and staffers and just nursing pay in general. Do you think that that's the answer? I'm not sure that increasing the pay is the full answer. certainly it makes us feel better and it may provide a temporary solution. But what are y'all's thoughts about that?
I think Jennifer spoke to that brilliantly earlier. It's getting to a point that we can't toss enough money at some staffing to make it all better. I think that of course we need to make sure that they're compensated to the level that they should be, but at some point it can't be about money. We want them to be in a career and a profession that they're compassionate about, that they love, that they're invested in, that they want to be in. And not all the money in the world is always going to make those things better. And so I think that we have to, again, goes back to a lot of my answer with my first question. We need to start rebuilding our design of our process. And I think that money isn't always going to be the answer to all of it.
No. And it used to be that money was not the reason people left an organization. So going back to those things, and I'm watching the chat, and you guys are exactly right. Ownership in the organization, to me as a nurse leader, means I have a say as a frontline caregiver in how the organization works. I really think, pay is fair pay, and pay that's equitable for the job you're doing. That's table stakes. But we need to have shared governance and really mean it, and not say, yeah, we are interested to hear what you think, but we're not going to do any of those items. And then we do need to look at, especially when we say we're depending and leaning on the ancillary teams, we need to make sure that the pay for the ancillary teams does not pull them to McDonald's. And so if we have, whether we have unit-based councils or shared governance structures in our organizations, if you're an AAC, you can do this to scale. How do we find out what's important to them? We ask. I think they'd be very happy to tell us. And I do think it's work-life balance. I do think it's some of those things like, why do we have doctors' dining rooms? We have doctors' dining rooms because, and some people don't anymore, let's face it, but we think that physicians are busy and their time of being productive is so important. And we want, them to just have these kind of things. We don't have nurses' dining rooms. I mean, I know there's a lot of stuff on social media right now about pizza, but I think a very sincere recognition of, yeah, we are in unprecedented times. What's it going to take to help you come to work every day? Is it a different assignment? Is it say in your assignment? Is there a piece of equipment that's always broken? Is there a colleague, frankly, that's toxic and nobody wants to work with them? That has a monetary value, and the only way you can quantify it, it's probably the 50 to 60 grand it takes to replace that nurse.
Okay, this is a really interesting question, and it says, has the increase in the number of nurses becoming hospital CEOs had any impact on the industry today?
I don't see that many nurses as CEOs, so I can't say that I've seen it affect much. I think sometimes nursing is lucky to have a seat at the executive table, so I haven't seen that affect as much. I have seen people don't want to stay at the bedside, so they keep going back to school. So I get brand new grads that want to be nurse practitioners or CRNAs before they even start their first day of work as a nurse. So I see that has moved people away from the bedside more than administration, I think.
Yeah, I think it's like some of this stuff. I was on a cool hackathon this week, and if anybody in the audience was on it, similar topic of saving the workforce. But when you talk about patients, I think the same thing is true for nurses. Your most difficult patient is not the clinically complex one. It's the wraparound stuff, the difficult family, the challenging home, or maybe they have no home. It's all of that. And I think with our nurses, coming to work and doing the job sometimes isn't the hard part. It is the wraparound. It's why do I have a crappy shift? If I can give you 4 hours today, why are you telling me to only 12 will do? Or if I have to bring my kids to school because school is different now with COVID, but I'll come right in and give everybody a break, turn over rooms and give lunch reliefs. Why aren't we trying to adapt to the wraparound that the nurse needs to be successful? I mean, if it was a patient, you would call it the social non-medical. I think the exact same is true for our nurses. It's the stuff that takes them away from the ability to do their job, not the job they're doing when they get here. They're great at the life hacks for that, how to make the work better, but we're not fixing what's making it hard for them to come to work. And I think, whether you're an RN as a CEO, I've never been a CEO. I've been kind of darn close, but everything then becomes a trade-off as opposed to the level I think where we're at, where let's be in pure solutioning mode, pretend we don't have to make those trade-offs and see what we come up with.
And I think, I think it's great. Anybody that wants to evolve their career, whether you're a nurse or not, and you're looking to move into that direction, I think that is awesome. I'm all about education, furthering yourself. And if your skill set leads you to be a CEO, awesome, great for you. I don't think it necessarily is a huge impact on nursing itself, what your individual goals are. I think how you implement and carry out your organizational and leadership goals is what matters. When you decide to move up in those types of roles, I think making sure that you stay steady with what the reason why you went to that type of position was for. If you want to stand up for certain platforms of nursing or for this or that, I think as long as you stay steady in those, objectives that you're looking for, I think that's what's more important. I say kudos to anybody who wants to evolve in those types of roles. I love to see very hands-on. I don't mean hands-on fact of going to take care of patients, but CEOs, no matter what role you're in, that you're there, you're walking around that hospital, those nurses' names, what they're doing every day. That doesn't always have to be necessarily a nurse, but it's great if they do. I just think being present, no matter what, as a CEO, having a great leadership style, making sure you're a servant leader and that you're out there and you're being impactful, you're saying hi to the right people, whether you're cleaning those floors or taking care of those patients.
And you have to do one thing that's actually hard for this talker to do. You, as a leader, have to open your ears because your mouth is open a lot. This is the initiative. This is what we want from you. These are our metrics. But if you're paying attention and listening, you can go all the way back to Quint Studer. If you listen, the workforce will tell you everything you need to do to fix it. We just have to have our ears open.
Excellent points, y'all. Those are just really great qualities of great leaders, aren't they? And being willing to speak up for the troops, I think, too, is important, because I think if the troops know you're willing to speak up for them, they're going to support you a lot more. So we've talked a little bit about technology improving nursing care. And this question is asking if we're making it sufficiently easy for patients and our nurses to access the technology and be educated about it.
I'll start with that one because I have a passion for this. And when we started forming this group, that was my big interest for being in this roundtable. I think that it can and does support high quality care. I think sometimes technology gets a bad rap. What we do have is a way to go before it's something I would ever define as easy. And so, something as simple as being able to use, a tablet versus having to wheel over to a PC. But I think someone said earlier, our patients are actually very tech savvy. I certainly know my colleagues and nurses that I work with are much more tech savvy frequently than me. So again, it's back to that listening, because technology does support, and in many cases, it's a safety net for high quality care. But we've really got to double down on this busy workforce to figure out how to make it easy.
And I agree a lot with you, Jennifer. I think that we do always have to make sure we want the technology to help us as a facility, but we also have to make sure that our end user, our patients that we're trying to get to use some of this technology, they're able to use it. So if you think about anything, any app that you open up on your phone or your computer or what is, you want it to be somewhat easy. Those apps that people can just kind of go through very quickly, those are the ones that are the most popular, that get the most attraction. So we need to be able to do that for our patients. We need to be able to give them technology that's user friendly, whether you're 35, 50, or 80, you can easily open up that technology and have it useful to you. So I think that that's definitely a really good thing for our developers. Create something that we can utilize that technology for good at a hospital setting, but that end user also, the majority of them can take that, use it, and live from that and actually have better outcomes from it.
Well, and Miranda, you're in the rural world, and so sometimes I think that's a different lens. What do you think?
Well, one thing I was thinking as you guys were talking was our nurses will use the technology whether we give them the right platform or not. So because they're used to having it in school, and that goes back to they don't tolerate our dysfunction anymore. So if they don't have a pharmacology app that's hospital approved, they're going to use one anyway. They're finding their own things and they're using their own technology. So it would just be nicer if we could be HIPAA compliant and be standardized with that. And I think that's one of the things I see the most at the bedside is, plus we don't always do a good job at optimizing using what we have, and making sure that we are well trained and well versed in that. Because I have found that we have some things at our fingertips that we just really don't have a resident expert. And so it's hard to teach the staff how to use that better when we don't really have anybody in-house that knows everything it will do for us either. And I think that's really important, is having that sort of tech support for clinical folks. Because if it doesn't work, then they're not going to use it. So that's one of the things, and one of the reasons why we haven't gone live with even scanning yet, because there were some bugs. And we find that with most technology, if you give it to them and it works for a minute and then it stops working, they're going to stop using it. So we really have to make sure our infrastructure supports.
Excellent. Just excellent points. This is an interesting comment that we have in the chat room, and I think we've pretty much addressed it, but it's coming from a little different perspective. It's coming from the perspective of a nursing student. And this student is asking, what would draw me towards becoming a permanent staff member versus becoming a travel nurse at the beginning of my career, or vice versa?
Ooh.
So many things.
That's an interesting one. I'm doing some travel work now, and one of the first questions I ask when I get to a place is, why do you stay? Because typically people aren't traveling around to well-functioning, highly staffed institutions, and invariably the answer I get is the people. They stay because of their team. And so I guess I would answer that from what I have heard is that if you're a new nurse and you come in and you feel like you're part of a team and you build that sense of community together and you're all invested, that seems to get people to stay through some pretty thick and thin times. That's what I've observed.
And my background in clinical education, I've spent so many years of my life with graduate nurses. And I can say to a new nurse, invest in yourself too, because the importance of you going to some place as a brand new nurse and really taking the time to absorb what you're doing, why you're doing, to make sure that you're safe and you're providing really good care for the right reasons is so important in the beginning of your career, to start developing that foundation. And to jump from a place to a place to a place, you're going to really impair yourself from having the groundwork built of why you're doing what you're doing. I'm not saying that you couldn't do it, you absolutely could, but some of those really phenomenal nurses are those people who have taken that time to understand why you're doing what you're doing and to really develop those skills before you jump into something to where you're going to be a little out of the comfort zone. You could hurt somebody.
I remember one day I was just driving around, and it happened to be Nurses Week. And I was driving by this large hospital, and there was this gigantic sign on the front of the hospital that said, we love our nurses. We appreciate them. They're the best nurses in the world. And I remember kind of stopping my car and just kind of looking at the sign and taking it in for a minute and thinking, wow, I wonder what it's like to work at a hospital where the nurses really, really are appreciated for what they do. And that's not only for nursing, of course, that's for all of our team members. But I think perioperative nursing, we do have that sort of team mentality. There is a camaraderie there that I don't think you get as a traveler. You only get that from that interpersonal relationship that you develop working day by day with your colleagues. So this question is asking, are we limiting solutions by our imagination and our traditional ways of thinking? And how can we be more innovative and more flexible in the ways that we deploy our nursing care? I think we've talked around this quite a bit, but maybe we can be a little more specific.
I think we are definitely limiting ourselves because we have to get away from that old normal, and we have to listen to our staff about what they want and what's important to them. And I have this conversation with my management team quite frequently. Do we want to stick to our guns and look for that Monday through Friday person who will work 2 to 10, or do we want some help, and let's job share, and let's bring students in, and let's offer shorter shifts as people are transitioning out of practice to retire? We have to harness their knowledge and figure out, hey, if you want to work a couple of days a week, or come in and help teach the Periop 101 class, or we're trying to get more creative. But I find it's a struggle in healthcare because we have not been very nimble. But I think it's what people are expecting of us now. And I think that's one good thing that will come out of COVID. We figured things out when we had to, right? We figured out how to do orientations for staff where we didn't have 300 people in a room. So it can be done. And there's no reason we should stop doing it. Like Jennifer said, post COVID, that all these things should go away. And let's keep being more efficient and keep using the technology at our fingertips and looking for better ways to do things, because I think that's just not how it's been in healthcare, and we haven't been very nimble. So
One thing that sticks out for me that Jennifer said is when she said, during this time, we stopped block time. I think all of my surgeons they'd be laying on my floor right here. They would just be laying here like, this cannot happen. I don't know who you are. So I think like that is the type of thinking, though, not everything is going to work that we try, but it's that kind of great thinking to say, okay, let's really think about this. What parts of this work? What parts of this can we make efficient and good for us? And what parts maybe do we still have to keep around? But I think that kind of weaving both of those types of thought processes in is where we need to head towards.
Yeah, I kind of framed it up when I was thinking about this meeting. I said, I think we need to take what works forward, leave what does not behind, and then develop new models that work for these times and be willing to try something new. I mean, maybe, Sammy, you'd have to say it to your people. What if there was no block time instead of let's take away all the block times? You don't need an AED. But I think if we take what works well, bring it forward. But some of those things that don't work well, like again, this model of I only want you 2 to 10, nothing else will do. Maybe we have to leave that behind so that we can develop new care models for the times we're in, because I think we are in new times. And so old thinking for new times doesn't really work.
And I think being progressive enough to accept that you're going to have those failures and you can still grow from them is really, really important, because that's how we're going to be bigger, be better.
Yeah. Excellent. I'm going to just open it up and see if there are any kind of final words you all would like to say. I'm seeing a lot of questions in the chat room, but they're all kind of things we've really talked about already in broader terms. So,
One
did you
thing
have
that
any?
I saw that we didn't really touch on was utilizing LPNs again. And I think that they are hungry for opportunities outside of long term care. And in my world, we have such a shortage of surgical techs too. We've tried to work with some programs to see if they would do an education line that would be an LPN focused on acute care and surgical services to teach them a little bit of that scrubbing, sterile technique, and the instrumentation. Give them other options, and then especially if they want to go back to school, then to be an RN, you kind of have your perfect OR nurse built in, right? Because they started scrubbing, and now they're learning to circulate as an RN. So we've been trying to figure out how to incorporate um, those nurses into our workforce again. I know we have gone away from the magnet model of having all BSN hires because in this world, you just don't have that luxury right now. Um, we, of course, encourage people to go back to school, but I think LPNs are an untapped resource that we really need to take a closer look at, and I think that's a really good point.
We have started since last year with the pandemic. We have started developing a lot more roles for LPN in our areas. I do know that we do utilize LPNs as surgical techs. We're able to do that in my area too as well. So that's something we have progressed a little bit towards because we too had progressed to predominantly zero, hardly any LPNs within our setting at all, to where now we do have filtered in a few more and we start to see the ability of getting some more in. So I think that is a great comment.
Yep, I agree. I think the only thing I would add, and this, I know we didn't touch on it, we focused a lot on what the frontline teams need. I have an intense concern about the nursing leadership team. I feel like that's sort of the next great resignation, if you will. And I think we absolutely have to focus and invest. And my message to the folks here, if you're nursing leaders on this roundtable, think about all the solutioning we talked about today. We need to apply it to our leaders. If you're across Periop and there's peri anesthesia managers, OR managers, SPD managers, how do we come up with flexible schedules for you all who have 24/7 accountability? Maybe that means, everybody works one day a week from home and that somebody's covering me while I'm gone. But the amount of emotional and physical intensity gone into the nursing leadership to get us through all this, and people that just held on to get their teams through. We have to focus on the fact that this is a nursing situation. This is not a frontline nursing situation, and make sure that we apply these same tactics to our nursing leaders, or we won't have anyone that wants to lead.
Amazing.
So true. So true. Those were just excellent. It's been delightful, y'all, and very thoughtful and provoking discussion. We're nearing the end of the hour, and so that's we're going to call that as the concluding thoughts for the day. As a reminder, the webinar has been recorded, and you can earn one continuing education unit for completing the quiz that will be available in your OR Manager account. So this concludes today's webinar. Thank you to all of our panelists. Thank you so much. And thank you once again to our sponsor, MobileSmith Health.